Hello, everybody. This is Pascal Fuchshuber. I'm Dr. Robinson, the chair of the FUSE committee, who is running this program today, has a little bit of technical difficulty. So I'm just going to jump in since I'm giving the first talk, the welcome and the overview. The FUSE program is a SAGES product that we're very proud of at SAGES. We've taken a lot of money in our hand and a lot of time and effort to put together the first really validated program to teach the entire operating crew what it is like to work with electrosurgical instruments and what are the best practices, the dangers, the hazards, and the things that you need to take into account and pay attention to. And that's what this webinar is all about today. Steve, can you run my slides, please? So I used to be a hepatobiliary surgeon, but I'm semi-retired now as an acute care surgeon, but I still do a lot of teaching. Can you advance the slides for me? Next slide, please. Today, I'm going to set your mindset both in a cognitive and an emotional way so that you're ready to take in all the information you're going to get. I'll start with the good. Next slide, please. For the last 3,000 years, what we have used in surgery is called and is cautery, as depicted here on the bottom. You can see the hot poker, the Chinese, the Romans, the army of Napoleon. Hemostasis and treatment of wounds was done with direct transfer of heat and hot pokers. Luckily, in the last 120 years, things have changed dramatically, and we have now systems that are based on electricity, a whole completely different concept with a whole completely different set of physical realities that you need to be aware of when you're a surgeon, especially now that when you walk into a modern operating room, there's at least 2 or 3, in liver surgery, maybe 6 devices going at once. Next slide, please. The bad and the ugly. Next slide, please. We have learned over the last 50 years from experiences. Next slide, please. We have learned that using electrosurgery in the operating room is a dangerous proposition. It is assumed that there are about 40,000 patients yearly just in the United States that are burned or die from electrosurgical device injuries. Next slide, please. So this is one of the most common things that happens. It's usually elective surgery. It's usually young people. It's usually a benign disease, and it's elective outpatient surgery. This woman, Lauren Wargo, agreed for her story to be shared universally. And this is her story. She was operated for a mole on her forehead. And because the surgeon, the anesthesiologist, and the operating room team wasn't really keen on how to do this without fire danger, she got a burn and was scarred for life. Next slide, please. Next slide. But you don't have to have a burn or die. Can you go back? You're going a little too fast. Can you go back one slide? Go ahead. Next slide. So you don't have to die or be scarred for life, but if you operate in the abdomen and you have what we're going to teach you today, electrosurgical burns, they can occur without any perforation, major complication, or death. But they do occur, and they do occur much more often than we think, because most of the injuries we don't see. Next slide. This is a picture of a young boy that underwent Nissen fundoplication, and 10 days after surgery died from sepsis, unrecognized perforation of the stomach. Clearly, you can see the full thickness thermal injuries in the fundus of the stomach on this pathology specimen, and on the other side, on the serosal side, there were many scars, just like the ones I showed you in the previous slide. These things happen, and we don't understand why they happen. And we are trying today to teach you and help you understand why these things can happen and how to prevent them. Next slide, please. This is another very prominent case of a senator of the U.S. Senate who died after a simple laparoscopic cholecystectomy from intestinal burns, perforation, sepsis. This made the news across the nation. Next slide, please. This is a patient that underwent prostate surgery and had an inadvertent colonic injury. You see the injury on the left side, on the right side, the same patient who survived after 7 operations. We assume and we know that there's about 2 million laparoscopic cases per year and 1 to 2 injuries per 1,000. So the large amount of cases, even with a very small incidence, leads to a great number of these injuries happening. Next slide, please. Next slide. Guess what this is? Anybody in the audience? I'll give you a minute to understand what this is, and then I'll let you know what it is. This is a young kid who underwent a surgery. This is an injury, a burn injury from a misplaced, not correctly placed dispersion electrode or return electrode. And this is a 3rd-degree burn on his knee. These things are 100% avoidable. Next slide. So the FUSE program, in a nutshell, next slide, is basically a book that you can purchase online that is called the SAGES Manual on Fundamental Use of Surgical Energy. It's one of the many SAGES manuals that are available. The book really deposits the entire knowledge around electrosurgical, ultrasonic, pediatric, smoke, fire hazard, and the other major part of the program is the online curriculum that is free of charge. It's 240 slides, takes about 4 to 6 hours to go through it. You can get CME credits. It's multimedia, and we will let you know how to get in touch with this program and take this program if you're interested. Next slide. The curriculum has 10 domains that are listed here. So here you can see all the objectives, the number of objectives, and the domains that you can learn how to do these things right. Next slide, please. It is a safety program for the entire OR. It's a team-building exercise. If everybody in the OR takes that program, you'll be surprised of the positive response of nurses and techs when they learn about this. And finally, next slide. If you're interested to become a teacher yourself for this program, you need to be FUSE certified. You need to take the FUSE certification test and you get a certificate. 80% of the people that take the test pass the test. It is not a big deal. And the test can be taken online. It can be taken at the ACS meeting, at the SAGES meeting.
Speaking to myself here. So that is the introduction to the FUSE program, and we're going to cover here in the next 90 minutes the fundamental topics that you should know about using electrosurgery devices, energy-based devices in your operating room. And Pascal just set us up for understanding that there's this content that's online that can really supplement the information that you're going to learn this afternoon. But we're going to kick it off with one of the stars, who's Amin Madani. So Dr. Madani is an endocrine and acute care surgeon at the University Health Network in Toronto in Canada. And he's really one of the champions for promoting FUSE education nationally and globally. There's Amin's picture, just came up online. And Amin's been involved with the program since its inception. And his biggest contribution is that he developed this validated simulation-based hands-on component for the FUSE simulation sessions. And his electrosurgery workshops run every year in four different continents across the globe, and it trains surgeons on the safe use of energy devices. So Amin, do you want to start us off with the fundamentals of electrosurgery?
Well, thanks, Tom, and thanks, Pascal, for the introduction and for asking me to be part of this. And thank you to everybody who's joining us around the world. Despite COVID times, it's nice to see the big turnout and for participating in this really important curriculum on the OR safety. So I'll just kind of dive into it. I'll give you guys an overview of the basic principles of electrosurgery, and we'll also talk about some adverse events and how things can go wrong using energy devices like the Bovi and so on. And then there's a question and answer session at the end. So if you have any questions, we can talk about them then. I don't have any disclosures. So there's various types of energies that we use in the OR. Probably the most common one is radio frequency. That's your Bovi pen, or people refer to it as cautery sometimes, erroneously. We also have, ironically, true cautery as well in the operating room. Other energy sources would include things like lasers, ultrasonic devices, microwave energy, and things like that. But by far, radio frequency electrosurgery is the most common, and so we'll focus on that for now. And I'll touch about the very basic principles behind it, and like I said, we'll touch on some of the adverse events too at the end of this talk. So how does radio frequency electrosurgery work? Essentially, you take electromagnetic energy, so alternating current, and then you convert that into kinetic energy in the ions in the cell. And it's that kinetic energy of the movement of ions that turns into heat and thermal energy that manifests into tissue effects. And there's various types of tissue effects that we'll talk about, but essentially you can do various things with it. You can either vaporize cells, you can desiccate, coagulate tissues, or you can fulgurate, which oftentimes people refer to as spray, which can result in a variety of different tissue effects. But it is not cautery. Okay, so essentially how it works is you have alternating current that's applied to the cell. Okay, you get a positive and negative charge, okay, on either side of the cells, but because it's alternating current, it switches back and forth. It alternates at a very high rate, and so the ions inside the cells move really fast to catch up to that, and it's that frictional force that raises the temperature. So I'll just play this little movie that really illustrates this.
When this type of current is applied to the cell, the alternating polarity causes those ions to rapidly oscillate back and forth inside the cell, including some large proteins. This process results in frictional forces that are responsible for elevating the cellular temperature.
So yeah, that kind of summarizes that. So what happens when you raise a temperature? You raise the temperature of in the cell. So we're start at 37 degrees Celsius. Sorry to my American colleagues, we don't have Fahrenheit here. But let's say you go up higher, between 50 to 60 degrees Celsius, that's where you start to get cell death. That happens over a few minutes. The cell membrane breaks down, the water evaporates, the cells dehydrate, and they die. What happens when you go higher? So between 60 and 90 degrees Celsius, you start to get instantaneous cell death. And there's two important things that happen in this range. Number one, the water evaporates, like I said, the cells begins to shrink. Okay, this is called desiccation. Okay, and at the same time, the proteins inside the cell, they denature. And then when it cools down again, instead of reforming in its original three-dimensional configuration, it reforms into these long strands. That's what these blue strands are. It reforms in a haphazard manner. Okay, this all forms that coagulum that we see. So you can get also protein coagulation too. So this is what happens in this cell range here. What happens when we get to 100 degrees Celsius? Well, what happens with water when you get to 100 degrees Celsius? It evaporates, right? So we call this cellular vaporization. You literally turns into this cloud of steam and ion. You can even go higher than that. You can go to 200, 300, 400 degrees Celsius, and it actually does really high different things at that high heat. You can actually take a carbon and it breaks down the organic material into inorganic carbon, and that gives you that carbonated hue, that black hue that you get at very high temperatures. That's from carbon. Or it actually can turn it into caramel. So the glucose and the sugars, at very high temperatures, it breaks it down into its sugar content. So that's why you get that caramel looking thing where it gets very sticky. So you can go at higher temperatures. This will be very important when we talk about different tissue effects, to understand how you can vary the settings on your electrosurgical device depending on what kind of tissue effect you want to see. So again, you get tissue desiccation, dehydration, and shrinking of the cells, and you get cooling down and renaturation in entangled manner, which gives you that protein coagulation that you get. So when you're able to take a blood vessel, and when you say somebody buzz me, and it seals the vessel, these are the effects that happen, okay? Now notice we haven't talked about cautery yet. So what is cautery? Cautery is the passive transfer of heat. So if I take a match and I burn my finger for whatever reason, that would be cauterizing myself. Or like Pascal mentioned, branding iron, taking a hot poker to cause heat. That's not what we're doing. We're doing something very different. We're using electrosurgery. We're not directly applying the heat. We're passing a large current inside the body to generate that heat. And this isn't just about semantics. It's actually, there are implications for using electricity. You can cause a variety of different problems with that. So that machine that has all the buttons and knobs, it's called an electrosurgical unit or a generator. And it does three different things. Number one, it converts the wall frequency output from 60 hertz to 500,000 hertz. I'll explain to you why it needs to do that, but essentially it's so that you don't electrocute your patients, right? You don't just pass electricity from the wall into their body and put them into cardiac arrest. You need to go at high frequency so that you don't depolarize muscles and nerves. So that's one thing. The second thing is you can actually set the wattage, the amount of energy per unit time that you're applying through the current, through the circuit. So when you tell somebody put it on cut 30, coac 30, that 30 that you're mentioning is the watts, the amount of joules per unit time, joules per second of energy that you want to go through your system. So that's what you're telling them to do, and that's one of the things you can adjust. And then the last thing is you can, depending on whether you use cut or coag, you're changing something called the duty cycle. That's the percentage of time that current goes through your system. We'll talk about that in a second. But essentially, that's another function you can vary in your with your ESU. And like I said, you have to convert the wall outlet from something that's above 100,000 hertz, because that's where muscles and nerves get stimulated. That's the threshold. Above that, they typically don't. So you need to do that. And just a word here, the radio frequency is something you use for a variety of different things. When you have two antennas communicating together, that's what they use. So we'll talk about that later. But essentially, antennas can communicate through air, through an insulator. And that's important because radio frequency electrosurgery that we use in the operating room can also communicate to other conductors through air. So it's an important principle to remember. So you have like a fancy antenna in the operating room that you're always using, essentially. So let's just simulate this for a second. What's the difference between cut and coag? So here I have an ESU, okay, and here I have an oscilloscope. Oscilloscope just measures the amount of voltage and current in your circuit. So we're going to demonstrate the difference between the two. So we're going to ask to put on pure cut. So when you use cut, you can use pure or blend. Pure means literally purely cut. So what does pure cut mean? So we're going to ask them to put it on 30, and then we're going to activate it. This is the current that we see in our circuit. So it's alternating current, so it goes back and forth, okay? And it's relatively low voltage. And throughout the entire activation, you have current that's going back and forth, okay? And if we were to say, okay, let's go up to 100 watts, it's going to look like this. So 100% of the time you have current going through the system, alternating current again, but it's higher voltage. So the amplitude is higher. So it means it's higher voltage, higher thermal energy. So now, and again, going back to 30. So this is a continuous waveform, and it means that the entire time there's current going through your circuit, and it's low voltage. How does that contrast to using coag? So if we go to 30, okay, again, it's the same amount of watts, the same amount of energy as we had on cut, and we activate, this is what it looks like. So notice a few differences. Your current is not going through the circuit the entire time, 100% of the time. It only comes during these brief periods. But remember, you told your ESU to put it at 30 watts. So you told it, I want 30 joules of energy per unit time to be delivered through the circuit. Okay, so by telling it you can only activate in these small intermittent bursts of energy, all that energy becomes concentrated now. Okay, so that's the difference between cut and coag. Coag, you're telling it to activate only with these small intervals of time, but at higher voltage, because all that energy is now concentrated there. So that's what duty cycle is. Duty cycle means 6% of the time current is actually going through your circuit. So it's an interrupted waveform, okay? It has higher voltage, and because of that higher voltage, you can cause other problems and causes different problems compared to cut. And what about blend? So like I said, when you press the cut function, you can either have it on pure or blend. And what it does is basically it's a continuum. So, in cut, you had 100% duty cycle. Coag, you had 6%. So blend is somewhere in between. You can have 50%. And different proprietary devices will have different functions. So you can have blend 1, blend 2, blend 3, and you can vary the duty cycle based on that. Okay? So again, pure cut is 100% duty cycle, low voltage. Coag is higher voltage with a 6% or lower duty cycle. So I'll just briefly mention a few things here, introduce a few terms. I'm not going to talk too much about monopolar and bipolar devices because Dr. Olaski will talk about that after me, but essentially the setup is as follows. You have an active electrode and a dispersive electrode, okay? This often is called a grounding pad. It's not a grounding pad because the patient is not grounded. Okay, so you have an active electrode and a dispersive electrode, and then the circuit is completed that way. So when you activate it, the current has to go through the body of the patient. We just see this tissue effect right there when we're operating, but it's about understanding that there's current going through the whole body of the patient. Bipolar instruments, you have two active electrodes. There's no such thing as a dispersive electrode. So when you activate it, the current passes through, but the good thing here is that the path is restricted here. So there's less areas the current can go to cause problems. Now, does it mean bipolar instruments are the answer to everything? No. So monopolar devices are very useful, very flexible and very dandy to use, but it's just about understanding how to minimize this current that could cause other issues. And like I said, grounding pads we don't do that anymore. So it's important not to call it that. Like I said, there's different tissue effects you can cause. You can either vaporize a tissue, you can either desiccate it and coagulate it, or you can do fulguration, which is that spray function that you see sometimes. I'll start off by talking a little bit about that. One of the misnomers here is the button on your Bobby pen. It's called cut and coag, but unfortunately, people think that cut and coag means cutting and coag literally, but it's not that at all. In fact, most of the cutting that we do is using coag. Cutting is just literally vaporizing cells. It's just a matter of how you do it. So let's take this example on the left here. So I apply a cut function, so it's low voltage, low thermal energy. I apply it here. I raise the temperature of the cells above 100 degrees Celsius, so this is going to vaporize. It's going to cut it, literally. But the cells around it are not going to experience a very high rise in temperature. It's going to bring it to the 60 to 90 degrees zone, enough to cause desiccation, but not enough to cut it. Okay, but because it's low voltage, the surrounding collateral effect is very minimal. So you're just going to see a lot of vaporization. You won't see too much desiccation or coagulation. Compare this to a high voltage setting like coag, for instance. You touch the, you make contact here, you're going to raise this well above 100 degrees Celsius and it'll vaporize, but because it's high voltage, it'll also cause a lot of collateral thermal spread. So you get a lot of surrounding coagulation and desiccation because of that. So that's important because you as a surgeon need to figure out, okay, what's the best function to use for whatever setting. I would love to use a setting like this for coag if I'm going through like muscle, for instance, or if there's a lot of tiny little blood vessels around here and I don't want it to bleed everywhere, then this would be a great function to use because I can do a lot of coagulating that way. However, if I have a very important structure, let's say I'm doing a dissection, I do a lot of thyroid surgery. So if I do, for instance, a recurrent laryngeal nerve dissection and it's right here, I don't want that collateral thermal spread to injure my nerve. So I may not want to use this function, for instance. I may want to use something like this, where you don't use a lot of collateral thermal injury. But let's say I'm cutting skin, for instance. Maybe I don't want something like this because it'll char the skin and it won't heal very nicely. I want fresh tissue edges, so I would use cut, for instance. So it's just a matter as a surgeon knowing what options to use. And these are they illustrate that example. So when you use cut, you have very minimal collateral thermal injury. Where you use coag, you get a lot of carbonization, caramelization, and surrounding collateral thermal injury. So this is like an example of going through adhesions. In avascular planes, you really don't need to use a very high voltage function. You're not going to cause a lot of injuries around there. So it's just about knowing your tool really well. There's this concept called current density. So the thermal effect is not just by the current that goes through it, but also the surface area that makes contact with the tissue. So if you concentrate your current very highly when you make contact with tissue, you're going to cause a lot more thermal effect. So take a bovie pen, for instance. You can either use the tip of it or you can use the flat part, and that's going to cause different thermal effect. So when you use just the corner here, the surface area is small, so the current density is very high. Here, you have lower current density because you're using the flat part of the blade. And you can use that to vary the thermal effect. So in this video here, you can see the surgeon is going to use the flat part. Okay, so that's a large surface area, low current density. And so it's enough to raise the temperature to the 60 to 90 degrees area for desiccation and coagulation. But when you start using the tip of it, the current density is a lot higher. So you get more vaporization instead. Okay, so you don't have to necessarily increase the watts on the ESU to get the maximum thermal effect. With that, I'm just going to wrap up by just talking about a few different electrosurgical injuries and things that can go wrong in the operating room. They're pretty common, and there's a lot in terms of medical legal costs related to this, and almost everybody knows somebody or a horror story that's happened. And these are how the mechanism of injuries are broken down. We'll talk about a few just to give you guys a taste of it, but essentially one of them can be related to the dispersive electrode. So again, the dispersive electrode is designed to be a large surface area to make it low current density because the current has to go through this, right? So you don't want any thermal effect here. So you want this to be as high of a surface area as possible. Things go wrong when this pad comes off. So if you put it on a bony prominence, someone who has a lot of hair, it may not stick properly. And you definitely never want to cut it either. You want to maximize the surface area. And if it don't, you can end up causing problems like this that we talked about earlier. The other major problem that can happen is you can get something called current diversion. Current diversion just means your current does not go through the path that you want it to go. And there's a variety of different ways this can happen. One of them is through something called insulation failure. So let's say you have breaks in the insulation and this is completely outside your field of view, and you can be touching other instruments that can divert current. So that's one way in which you can have current diversion injuries happening. And the smaller the break in the insulation, the higher current density because it's a smaller surface area of contact. And often these small breaks are not visible to the naked eye, so these are particularly problematic And we have monitoring systems to figure that out for us. The other kind of type of problem is called direct coupling. So that's directly when you couple your conductor, your active electrode, to another conductor. So when you say somebody buzz me, you're doing direct coupling intentionally in that case. But if your metal is touching another metal, that's inadvertently, and you can divert current and cause a burn like in the skin here. Or in laparoscopy, you could touch, like, say, the laparoscope and activate it, and then it touches bowel, let's say. So direct coupling is another thing you need to be careful. Always make sure your tip is in your field of view and never activate it inadvertently. One type of direct coupling is this thing called metal-to-metal arcing. So, you have a staple line, and sometimes it oozes a little, and it's so tempting to just burn the bleeding. But the problem is, if you burn the staple line, you're burning a small surface area. Those metal clips are small surface area, and it concentrates the current very well because it's a very good conductor. And that can actually raise the temperature above 1,000 degrees and melt the metal. So you definitely don't want to do something like this, okay, on your staple line. Okay, that's going to melt you see that you're like melting and causing sparks everywhere. So it can cause tissue breakdown and anastomotic leaks. Finally, the last thing here is capacitive coupling. Capacitive coupling is, like I said, it's like you have antennas that you're working with in the operating room. Just because this is covered by insulation, and let's assume for argument's sake this is truly, there's no break in the insulation. Just because I'm looking at the field of view, the metal tip, it doesn't matter. You can have things happening outside your field of view without you even knowing about it. Imagine there's another conductor beside it. You can actually communicate like antennas through insulation, through air, to that other conductor and induce a new current in that other conductor and then cause a burn somewhere completely outside your field of view. That's called capacitive coupling. So I'm operating here, I'm activating this instrument, and it's a fully insulated instrument, and then it communicates like antennas to this metal cannula, and then it induces a current there without you knowing about it. That's called capacitive coupling. And this example we'll just show here. So let's say you have a piece of ham hanging by your instrument. Okay, so this is a fully insulated instrument. Okay, you're not touching anything here, but you have this piece of ham hanging, and it induces a current in this ham. And you've completed the current by touching this piece of meat here. So even though you have a fully insulated instrument, you can do that. Okay, and the key here is, and this is one of my pet peeves in the OR, is when people activate their instrument without touching the intended target. So if I'm activating this in open air like this, the current has nowhere to go except through this alternative path. So you want to make sure that you're touching the target tissue so that even if you have a path like this, you make sure that most of the current still goes where it's supposed to go. So never activate this in open air. So other things that you want to avoid is avoid high voltage. So don't use coag if you don't need to. Avoid high power settings. Like I said, don't put it on open activation. And the other thing is don't activate it over previously desiccated tissue, because the previously desiccated tissue, that charry stuff that you keep burning, it's just an insulator. So it's like you might as well activate it in open air. Okay, and finally, a direct thermal extension. We talked about collateral thermal injury, so just be very mindful of that. Make sure you use the lowest possible setting, especially if you're doing these nasty gallbladders. You're dissecting in a frozen triangle. You know there's structures that are there that are critical, so you can directly extend that thermal injury and cause, let's say, a biliary stricture or a duodenal burn. And always avoid use short activations as much as possible. Don't just crank it and hold it for 30 seconds nonstop. Give that time for it to cool down. Okay, with that, I'm gonna terminate my talk, and thank you for having me.
So listen, Amin, thank you. That was an excellent talk. I just want to give a couple take-home messages, and then we've got a question on the chat box for you. So a couple take-home messages for the group is high voltage modes, and notably the coag mode, those put you at most risk for unintended thermal injury. So it's the high voltage mode. Voltage is the electromotive force that pushes the current out the tip of the instrument. So that's what we want to watch for. And then the other, I think, key concept is current density. So the smaller the surface area of your tip of your working instrument that's on the tissue, it's exponentially, not linearly related to the amount of temperature. So the temperature goes up exponentially. And so I think those are two of the big take-home points from fundamentals of electrosurgery. So Amin, I'm just going to, just because we're a little bit over time, but I want to answer the one question that's up on the screen for you, and then we'll move on to the next talk. But the question was up above here, and the question basically is, look, what mode is the best mode when you're buzzing an instrument for hemostasis? So you have your DeBakey's, you grasp a small blood vessel, and then you want to use your electrosurgery to get hemostasis. Do you recommend coag or cut, and why? Can we still hear me?
Well, that's a very good question. Sorry, can you still hear me?
Yep, I can hear you.
Can you still hear me?
Yes.
Okay, perfect. That's a great question, and actually, that's a great segue to our next talk. I believe Dr. Olaski is going to describe this in a lot more detail, but I'm happy to answer it now, Tom, if you like.
Yeah, no, go ahead. I mean, we've got Jason's a couple talks
Hello?
down the road, so why don't you just give a brief answer and we'll move on to fires next.
Sure. Sure. So basically, the answer is you want to use the lowest. You want to use the lowest voltage necessary to cause a seal. When somebody says buzz me, you want to use something like cut. And the reason is because of it's a little counterintuitive, right? You think you want the highest maximum energy to really seal it really hard and really burn it. But the problem is when you do that, it causes a very heterogeneous burn in the vessel that you have in your DeBakey. It's not very homogeneous. It's like basically burning a piece of steak on a very high temperature pan. It doesn't cook the inside very nicely, but it gets the outside very well. And then what happens when it burns on the outside, it becomes an insulator. So the inside never really cooks properly. So what you really want is something that cooks it slowly, more homogeneously, and eventually the seal becomes much better. So cut is actually better. So in fact, those devices like the ligature, advanced bipolar sealing devices that are designed for hemostasis actually use continuous waveforms. And the other thing to note is, remember I was telling you about that caramel phenomenon, the caramelization? If you use high voltage like coag and it caramelizes the vessel in between your DeBakey's, and then you let go, that stickiness just releases that seal that you just formed. So it's not as good for a number of reasons. So it's counterintuitive, and we're all taught to use coag, but unfortunately it's better to use cut. And the other thing is it just takes a little bit longer to cause a seal than coag. That's all.
Perfect. Amin, thank you so much. There's more questions, but I just want to be respectful to the other speakers, so I'm going to keep it moving. But we may come back to other questions for you at the end. But thanks so much. All right, so now we're going to move on to Dr. Edward Jones, who's going to talk about fires in the operating room. And Dr. Jones is an associate professor of surgery at the University of Colorado, works at the Denver VA, and Dr. Jones has published on fires, particularly with skin preps, and he's always encouraging me to come to him in the lab because he wants to add oxygen to the mix, and so I think maybe he's going to discuss with us why that would be a good or bad idea. Eddie?
Sure, thank you. Thank you to the FUSE committee, Dr. Robinson, Dr. Fuchshuber, for the opportunity to present operating room fire, something I feel very strongly about, I guess. I don't have any disclosure. Sorry, I don't have a disclosure side. So this is kind of what we're going to go through. We're just going to briefly define what an OR fire is, because I think people have certain things in their mind, and that may not be exactly what the Joint Commission or what we all should have in our mind as a fire. We'll look at the incidents and then really kind of focus on what we can do to prevent them, and also touch base on what to do if a fire starts in our OR. So everyone has in mind this idea of this beautiful campfire flame. But unfortunately in the OR, and running away and screaming, most fires are going to be alcohol-based fires, and it creates this nice blue flame, which, as you can imagine, when we include our blue drapes, can be very, very challenging to see. And it can be so challenging that it can actually burn for a little while, harm the patient before we even realize it's there. And so this is kind of one of the big reasons why we need to be very aware of it and very focused on prevention. This is kind of the definition of it, and the reason I bring this up is mostly for that second sentence. And I'm sorry about my kids in the background. Let me yell at them really quick just to get them to quiet down. Lily, can you be quiet, please? So you can see there on the bottom, a smoldering condition without a flame is still classified as a fire. So what this brings to mind is exactly this. So this is still considered an OR fire by Joint Commission. And if this is seen, I remember as a fellow, we had one of these in the drapes, and that was reported as a fire and a burn. And I don't think that this in and of itself does that hurt the patient, not typically. But it's what this can lead to that I think warrants our close attention and prevention. So how common do these happen? It's very, very hard to tell. There's no mandatory reporting mechanism. As far as we can tell, the best data comes out of the Emergency Care Research Institute out of Pennsylvania. They did a health database review, and they defined it at about 500 to 650 events per year. My personal suspicion is it's much higher. Very few deaths. So why do we really care? Well, for one, Doug Overby at University of Colorado did this nice look back through the MAUDE database. It's a FDA voluntary reporting database, and found out that the incidence of these fires seem to be increasing overall. And even more so than that, as Pascal already kind of presented, is all it takes is one event. And all of a sudden, not only is that patient's life changed, but the surgeon's life has changed. It affects the entire operative team, and it can affect the entire hospital system. It's not uncommon for one of these things to happen, and all of a sudden everyone is doing fire training, renewing, and kind of getting prepped for the next terrible event, which hopefully never happens. So how do we prevent it? Let's get really kind of into it here, and we won't take too long. So fires, as you may recall from grade school, are built of three different things. They require a fuel, a heat source, and an oxidizer. In the operating room, our oxidizer is almost always not oxygen. It can be nitrous oxide. Our fuel source is typically an alcohol-based skin prep, but drapes, gowns, even the patient's own hair and tissue can also serve as fuel. And our heat source is typically our electrosurgical unit, such as the Bovi, can be lasers, fiber optic lights, and what have you. So let's just focus on each of these separately. So an oxidizer, a nice closed claim analysis from the last 10 years looked back and identified that the vast majority of OR fires in this closed claim analysis, so malpractice claims, were in the head and neck or upper chest. The vast majority monitored anesthesia care. What does this mean? It's all about the supplemental oxygen. An endotracheal tube is not perfect, but far worse than that is a nasal cannula blowing extra oxygen in there. Far worse than that is a mask blowing extra oxygen on the patient. And you can see there how much it increases the room air oxygen content. So 21% is room air oxygen. You put on just a little bit of oxygen, less than 4 liters, you can bump it up about 5%. You turn them up to high flow, all of a sudden the room air oxygen content can increase 35 to 50%. And you do some weird kind of drape thing that I found on the internet, I mean, that's a perfect problem right there that we want to avoid. And so what I really want you to focus on is this idea of 30% oxygen content within the room. So all that takes, maybe 5 liters nasal cannula to increase our oxygen content to greater than 30%. Why does that matter? Nice study by Bill Cupp out of Texas, looking at different drapes and gowns and what have you in the operating room. And you can see on the far right, we have class 1 normal flammability for our utility drape, our gown. A lot of these things, class 1, are really not supposed to be all that flammable. And in fact, without increased oxygen, room air oxygen, you can see your drapes and gowns don't light on fire. But you turn it up just a little bit, ignition time and 50% oxygen, you put that patient on that 6 liter of oxygen, and all of a sudden these things are lighting on fire in less than a second. And even more so, your operating room towels, your surgical drapes, you turn it up just a little bit, and these are disappearing in 7 seconds. That surgical drape has burned in 4.5 seconds. And so this is why I bring up the oxidizer first and foremost, because it is absolutely one of the most important things we need to consider when we're doing these procedures. And here's just another visual depiction of burn times. As we turn up the oxygen, it takes 20 seconds for a blue towel to burn. As we turn it up, it's burnt in less than a second. And so this is really an essential thing we need to concern ourselves with. So you can consider a closed oxygen system such as an endotracheal tube. It is not a guarantee, but it is a lot more effective than a nasal cannula or monitored anesthesia care. So if you're still going to do that procedure on the face, it's a low-risk procedure, and you want to give them a little oxygen because they're a little older, maybe they got COPD, then just use your knife and use your good surgical technique to stop bleeding. All right, moving on to a second part of the fire triangle, heat sources, surgical energy, 90% in that database review. 90% of fires were started with a surgical energy device. Lasers, light cords, I haven't seen any specific fires from a light cord, but we have seen patient burns from that. So when I think about energy devices, you want to select the lowest risk device for the procedure. So we're putting in a trach. We get into some bleeding. Are we going to reach for some kind of energy device? Probably not a great idea, right? Let's use our good surgical technique, put a stitch in it, and get the bleeding stopped. Now, if that happens in a patient who's intubated and we're working in the abdomen, coming through the abdominal wall, then I think it's totally fine. Your risk of an OR fire is very, very low to use that energy device. So we need to just keep in mind where we're working and what is the best way to stop that bleeding. All right, so we worked our way through oxidizer heat. Let's focus on fuel. This is some research that I was able to do with Dr. Robinson and some teammates, and we looked at non-alcohol and alcohol-based preps, and the data is right there in front of you. I could not light a fire with a non-alcohol-based prep. You use plain chlorhexidine, use plain iodine, can't light a fire, even after waiting 3 minutes. If you use an alcohol-based prep, we can still light a fire up to 10% of the time after 3 minutes. And this is kind of an example of the fires that you can light. This is a piece of porcine skin that we use, and we confirmed our fires with some nice thermal imaging. So these aren't just little kind of whooshes. As you can see in panel C there, these can be a full-on flame that can truly harm the patient, maybe even the operating team. So we really kind of drilled down into what can the operating surgeon do, what can we affect the most in order to reduce fires, and pooling is the answer. So you can see when you allow pooling of the alcohol-based prep, and it always reminds me because I'm a general surgeon, I'm thinking of the umbilicus, it is nearly impossible not to light a fire. You can see that there, 95% of the time we could light a fire after prepping without waiting 3 minutes, 75% of the time even after waiting for a 3-minute delay, and there's still a little bit of a pool there. So we have to take care of those pools. All right, so in summary, we need to avoid our alcohol-based skin preps in areas that are high risk. I think it's perfectly reasonable to use plain chlorhexidine up in the head and neck. The data with respect to infections is somewhat marginal out there. I know we've all kind of agreed to start using chlorhexidine. The CDC guidelines came out and said we should be using a chlorhexidine alcohol-based prep, but I think we need to take this with a grain of salt and look at our patient and look at what we're doing to our patient. And if we got that patient on a high-flow mask because we're working on the head and neck or the face, maybe that's the patient that we accept a marginally higher risk of infection by using plain chlorhexidine or plain iodine and reduce that risk of an OR fire. 3-minute dry time is not a guarantee. That's manufacturer required, but does not eliminate the risk of fires. Avoid the creation of pools. You see a pool in the umbilicus or anywhere else, even in the drapes. It can drip down alongside the drapes. That's why we're all not supposed to drape before 3 minutes. We got to be keeping in mind the idea that we got to get rid of these pools, dry them up. And I see that question on non-alcohol-based options. The two big options, Dr. Inga, are plain chlorhexidine and plain iodine. People sometimes use plain alcohol. I wouldn't recommend that, but those are the two big options out there. All right, so there are a bunch of fire risk assessment guides out there. I think this is important. We incorporate at the VA where I work in all of our timeouts, and I think it keeps fires in mind and helps us all think about them. I would totally recommend them if your institution doesn't do them. All right, so what do we do if a fire starts? We run away screaming. Pull the fire alarm. No, we need to stop the flow of the gases. So if the patient is intubated and you're working on the airway, we need to stop that. Disconnect the breathing circuit, turn it down to 0 oxygen. And everyone kind of panics in their head and is like, oh, the patient's not going to have any oxygen. This all happens in the span of about 5 seconds. So we need to disconnect it to get rid of that high oxygen environment. Remove the nasal cannula or the face mask. If they have an endotracheal tube and this is an airway fire, you pull that tube and you can pour saline in the airway to stop it. Second, and again, this all kind of happens simultaneously. Usually you're talking to anesthesia to stop the flow of airway gases while you're removing all the burned and burning material from the patient. You're using saline or whatever you have nearby. You can even throw some drapes or a towel on the patient and kind of pat it out. And then you're going to restore breathing and care for the patient. At no time did you see that I said, go and run and pull the fire alarm. That is exceedingly, exceedingly rare that a fire is going to get out of control in such a nature that that's going to need to happen. The vast majority of the time, if your team has trained in this, has a little bit of knowledge in this, this will all take less than 5 seconds for you to do it, stop the fire, and preserve the life of the patient. All right, so just focusing on prevention. We want to avoid the use of oxygen in an open fashion that raises the room air content greater than 30%. So I'm thinking about 5 or 6 liters nasal cannula. If you're going higher than that, either try to avoid an alcohol-based prep or use a closed circuit, use an endotracheal tube. When you're using your energy device, use it in a smart fashion. Don't use it near the airway if you don't have to. Try to avoid the creation of sparks in and of itself. So fulguration, where you're creating that forced spark gap, is not a great idea when you're working near the head and neck. Now, if you're working on the foot with an endotracheal tube in, I think that's perfectly reasonable. And finally, if at all possible, in high-risk situations, especially avoid alcohol-based preps. And when you use an alcohol-based prep, avoid the creation of solution pools. And that's it.
Okay, thank you, Eddie. So I think understanding the fire triangle is really critical. I won't go over it again. But then the other question that I think is on the app site and certainly is on Fuse is the immediate response to an airway fire. What he recommends is if they ask on the app site, what is the immediate thing you do if there's an airway fire, what should anesthesia do?
Here it is again, just so everyone burns this into their brains. You want to stop the flow of gases, disconnect the circuit, or remove the endotracheal tube. So if it's an airway fire, stop the gases, disconnect it, pull the tube, and then extinguish the fire, usually pouring saline or whatever you have handy down into the airway.
Great. And Dr. Kittmer, I'm going to save that question for the end. I think that was somebody under a MAC, a monitored anesthetic care. Oxygen got trapped under the drape, and then they were doing electrosurgery on the head and neck and caught a fire. But we're overdue by about 15 minutes already, so I want to keep us going. So Eddie, thank you. Great fire talk. We're going to move on to a new topic for Fuse, which is on surgical smoke and aerosolization safety. So Dr. Mikami is going to give this. So Dean is a professor of surgery at the John A. Burns School of Medicine at the University of Hawaii, and he's the division chief of general surgery. He also is a real leader at SAGES. He's the chair of the Education Resource Committee. And I would say that for this talk, Dean is really taking the lead for SAGES of trying to understand smoke and then aerosolization in this new era of COVID. And so, Dean, do you want to help us understand safety around smoke and aerosolization in the operating room?
Sure. Thank you very much for allowing me to give this lecture. So for SAGES, we actually had a webinar probably a few weeks ago on the COVID-19 era and laparoscopic surgery. So it sparked worldwide questions. And this is a little bit of an offshoot of that lecture, but I'll try to get through it because I know we're running behind time here. So this is a very important slide. So why is surgical smoke and aerosolization important? We know that there's over 150 different chemicals that are toxic in the surgical smoke that we see in our ORs every day. We also know that multiple viruses have been known to be passed through laparoscopic surgical ports through our CO2, such as HPV and hepatitis. Right now, we don't know about the SARS-CoV-2 virus, if it could be passed through, but we have to assume that it is possible. So there are different ways to mitigate the risk of surgical smoke in the OR. We're going to talk about smoke evacuation systems, other devices to capture smoke, vacuum sources in your OR, and mitigation factors that you can do for yourself. So I'm going to go through filtration in general, and as surgeons, we need to know about filtration. It's very important to protect ourselves, to protect our staff, protect our patients. So filtration may be an effective means of protection from the release of smoke and potential sources of infection during surgery. We all know about our N95 respirators that are designed to filter out 95% of particles greater than 0.3 microns and larger. And throughout this lecture, I'm going to use the term microns to kind of describe virus particles and the size of it, and in relation to our N95 respirators. I'm sure everybody's heard of HEPA filters. So basically, a HEPA filter can filter out 0.3 micron particles or greater at a 99.97% efficiency. And a term you might not have heard about, but is very important to your health and safety, are ULPA filters, or ultra low particle air filters. They have the ability to filter out 99.999% of particles greater than or equal to 0.12 microns in size. So another important factor to know is what are the mechanisms of filtration that are being used in the operating room and in your mask. So definitely a mechanism is straining, which includes, if the filter particles are created in such a way that they're tightly wound, the particle can hit the filtration media and get caught. Inertia impaction implies that as the particle flows through linear flow at a certain rate, it will hit the fibers immediately on the fiber and get caught. Diffusion is a little bit harder to understand, but it's usually random motion, so Brownian motion, especially very small particles. They kind of oscillate through the air, and this oscillation is a good principle for us, because as it oscillates, it can get caught on the filter material and get filtered out. Other mechanisms such as diffusion, or actually the particulates can actually get caught on the filter media and get intercepted, and also get caught that way. And another mechanism is electrostatic attraction. The media fibers of our mask have electrostatic attraction built into it, so it can get caught through electrostatic attraction. So filtration in the operating room, once again, very important. It should be used for all laparoscopic, open, and endoscopic procedures. We use a multifaceted approach: proper room filtration, ventilation, appropriate PPE wear in the operating room, and smoke evacuation devices with a suction filter, most preferably an ULPA filter. So engineering controls in the OR that we use, usually every operating room has a standard 15 exchanges per hour. So every 4 minutes, the room oxygen should be filtered through. So, if you have a patient that is high risk, that is maybe positive for COVID, or is a PUI person under investigation, you should wait at least 4 to 8 to 12 minutes, so there's multiple air exchanges that are happening in the operating room before entering the operating room. So we know with use of electrosurgical units, it can raise the concentration of particles in the air from 60,000 to 1 million particles after 5 minutes of use. And 20 minutes after using that, the room can get cleared out by our whole room filters. So most ORs, if not every OR, is designed to be positive pressure, meaning that we want to keep the dust from entering our doors, right? So the room is positive pressured, so it pushes air out the room to prevent dust from being suctioned into our OR. Unfortunately, if we're operating on a COVID patient or a patient that has an infection, we don't have that negative pressure suctioning the virus out of the room. We rely on a HEPA filters for this. So best practice is to intubate our patients in a negative pressure room and bring them to a positive pressure room after. Other engineering controls that are used in the OR are ULPO filters in our filter canisters, inline ULPO filters to the wall suction. We have smoke evacuators that go to the instruments that we use, and smoke evacuators can be also placed on pencils that we're using in the OR. So the National Institute for Occupation Safety and Health, or NEOSHA, has this hierarchy of control. So basically it talks about everything we've mentioned so far. So this upside down pyramid, the top being the most effective thing we can do. So definitely elimination of smoke or other physical hazards such as viral particles in the air that get aerosolized can be controlled by OR ventilation with the 15 exchanges per hour. The next line of defense is substitution. Let's replace the hazard with something safe. So this is the utilization of positive/negative pressure rooms by pushing the virus out of the room or suctioning the virus out of the room or the smoke out of the room. Engineering controls. So we isolate people from the hazard. So once again, only necessary personnel should be allowed in the operating room for these high-risk patients. Administrative controls. We change the way people work and think. So we educate our OR staff and our surgeons and our students on the best mitigation techniques to be used. And unfortunately, our least effective mechanism is our personal protective equipment, our surgical masks and our respirators. So I think this is a very good paper, and this is something we all need to understand, is this principle about protection factor. So every N95 mask is assigned a protection factor. So what that means is it's the count of particles outside your mask versus the count of particles that get inside your mask. So we want particles to stay out, and we want viruses to stay out of our mask. So 1 is the worst protection factor, right? That means for every 1 virus out there or 1 smoke particle out there, there's 1 inside our mask. So we want a large number, a higher number for a protection factor. The standard protection factor for our N95 mask is 10. So that means for every 10 smoke particles out there or viral particles, there's 1 inside our mask. So the key thing is on an infected patient, you want to stay out of the viral plume or the smoke plume if we're working in the OR, because the closer we get that 6 feet radius, the higher the chance we get our smoke particles into our mask or our viral particles into our mask. So in this study, they looked at viral particles, or particles from 0.04 microns to 1.26 microns, which is the size of the SARS and the SARS-CoV-2 viruses. They found that N95 respirators perform worse between 0.04 and 0.2 microns. The protection factors in this mask were between 10 and 60 with particles of this size. So we know that particles can get through our mask, but still these N95 respirators are 8 to 12 times more protective than our surgical masks. However, in the study, 29% of the tested N95 respirators had protection factors of less than 10. So what does this mean? So when you're looking at your N95 mask and you're trying to look at the specs, right? It's the typical 3M N95 mask. We see the assigned protection factor of 10, which is the average. We also see that it has advanced electrostatic media, one of the filtering mechanisms that we use to protect ourselves from viruses and smoke. So I'm going to quickly talk, and I'm sure everybody's heard a lot about the SARS-CoV-2 and or SARS-CoV-2 and the COVID-19 disease process. So basically, it's a very small RNA virus that has a size range of 0.06 microns to 0.14. So very small virus. It's been found throughout the entire body, nasopharyngeal tracts all the way down to the colon and the rectum. So when you compare the SARS-CoV-2 virus and you look at the size, that's why it's very important that we know about filtration. It's a very small particle. Our HEPA filters, can pick up these viruses, even though they only filter out 0.3 microns and larger, but with the other mechanisms, it can pick up a lot of these viruses, but you're best protected by an ULPO filter with these viruses. So what's very important is to know how are people in the healthcare profession getting infected. We all know that it's been around for months now. Everybody's wearing PPEs. Everybody's wearing N95 respirators. But still, there are over 600 healthcare workers in the world that have died from COVID-19. So definitely respiratory droplets are probably the most common way. When somebody coughs or sneezes, saliva particles are suspended in the air, usually within 6 feet. But this is where a surgical mask and N95 respirators can protect you. It can catch the virus particles and prevent you from inhaling the viral particle. We know that fomites are transferring viral particles after touching contaminated surfaces, and you touching your eyes can get you infected. The thing that I think most commonly is that aerosolization of these small particles are going in the air, and we're taking in viral particles, and that's how we're getting infected. But currently, for the OR, there's no evidence that SARS-CoV-2 via surgical smoke can be transmitted, but we know that other viral particles can be transmitted, so we're very cautious about this. So very important to know, what is the infectious dose, the amount of virus necessary to make me sick? So we know from other viruses, norovirus, it only takes 18 virus particles to get you infected. Influenza, only 10 viral particles. SARS-CoV-2, most scientists think it's a very, very low number. When somebody coughs or sneezes in a 6-foot radius, scientists have said that there could be hundreds of thousands of viral particles floating in the air in that 6-foot radius. So that's why you need to understand that your mask can protect you, but you got to try to stay out of that 6-foot radius to try to stay protected the most. So quickly, in the last few minutes, I'm going to talk about ways we can help ourselves in the OR. If we know in open surgery, if smoke is not evacuated, it can be detected for 20 minutes after an energy device is used. Using cut and blend modes have shown to transmit bacteria and human HPV. Using higher voltages or power, such as coag, can reduce the risk. The risk is also reduced with N95 masks, but we know that hepatitis B, at least, is detectable in smoke. So best practices is all pencils should have a ultra filter suctioned out near it. If you're using a regular Yankauer sucker, it needs to be hooked up to an ultra filter. If possible, keep it 2 inches from the source. It can suction up to 95 to 99% by using this mechanism. Also, having an ultra filter in the OR to filter out the air is a good practice. For laparoscopic surgery, make your incisions as small as possible. Use ultra filters. Use the lowest peritoneum pressure to operate with. When you suction CO2 as smoke, don't use your suction irrigator. You should use your valve ports that are hooked up to an ultra filter instead of using wall suction. Use the lowest power settings possible with electrosurgery, and don't let CO2 escape out of the port sites unless it goes through an ultra filter. If you are operating on a potential COVID patient or another patient with hepatitis or HIV or flu or HPV, all members in the OR should wear N95 masks, appropriate gowns, face shields. If you are converting to open surgery, you should desulfate the abdomen before opening. If insufflators are being used, do not have, make sure you close the valve on your insufflator before kind of stopping surgery. If the patient coughs, you could blow CO2 gas into your insufflator and eventually contaminate your insufflator. Specimens should be removed once the CO2 gas or smoke is filtered out. Avoid suture closure devices laparoscopy because they can cause leakage of CO2. And hand-assisted surgery should be avoided during this time. So basically, this is the SAGE's recommendation. This is what we kind of talked about. And since I want to say something, I have a couple more slides, but I think this is a very good conclusion slide. Everybody should be protected in the OR. Use your PPE. Laparoscopy, there's very little evidence of COVID-19 spread, but basically we know other viruses can spread through CO2 gas and smoke. use HEPA filters, or sorry, use ALFA filters to filter out smoke and CO2 gas, minimize use of surgical energy, and make sure if you're going to operate on these patients, to test your patients before surgery. I'm going to stop here, and then we can answer questions at the very end.
That's great, Dean. And so can you just flick back to your slide that was on the different sizes of the viruses? There was a question. If you don't mind just scrolling back to that particular slide. And then I had some comments, but let's just get to Dr. Kittmer's question and then we'll move on. So Dr. Kittmer asked, never heard of an ULPA filter before. Is it something that has been standard on smoke evacuators, or it is a new thing that ORs are having to source, purchase, and add to their machine?
Yeah, so ULPA filters.
Can you comment on those filters?
Yeah, sorry. ULPA filters have been around for a long time. So every smoke evacuator, and I skipped some slides at the end, but I'm gonna show you some slides at the end. So here's this is on the Sage's website actually. If you use these type of insufflators, almost every insufflator besides the Olympus has a built-in ULPA filter for smoke evacuation. So, for instance, the Stryker Pneumoclear has an ULPA filter in its design. If you're using aerosols, it has ULPA filters. Once again, almost every one has an ULPA filter in it.
Great. Okay, listen, thanks, Dean. I really appreciate you putting this together. This is a new area for the Fuse group, and we appreciate you championing it.
You're welcome. Thank you very much for your time.
So, yeah, thanks, Dean. Okay, so Dr. Orlowski is next. And so Dr. Orlowski is a minimally invasive general surgeon and assistant professor in the Department of Surgery at Mount Auburn Hospital at Harvard Medical School. Jason is the co-chair of the Fuse program and a member of the SAGES Educational Council Assessment Group. And so Jason is going to talk to us today about monopolar and bipolar devices, which will really springboard off of what it means to start us off with. So Jason, do you want to go ahead?
Yes, thank you. Can you hear me okay?
Yep.
Okay, great. So I'll be going over monopolar and bipolar devices. As Dr. Mandani mentioned earlier, he made the nice foundation and groundwork for what I'll be talking about, which is a little bit more of the clinical application of the science that you learned from his talk. So we won't do too much of a recap on the science, mostly just the clinical. I don't have any disclosures. The objectives of this session, this next 10-15 minutes, are to learn about specific monopolar instruments. We'll understand a little more about how bipolar instruments work, talk about advanced bipolar instruments, and discuss briefly clinical decision-making in terms of which instrument you choose to use. So jumping right in with some monopolar devices, these should look pretty familiar to everyone. They're all laparoscopic. Obviously, there's open monopolar devices, such as our electrosurgical pencil that we've been talking about, the one that's often erroneously called the Bovie pencil. But the monopolar devices you see here, we have our Maryland dissector, our shears, our hook, and our spatula. At least I call it the spatula. So once those are hooked up to typically the green cord, or depends on what system you have, some places have the electrosurgical pencil itself, one that connects to a laparoscopic instrument. And so these are all going to be monopolar devices, and a little more detail on that. The reason we don't say monopolar energy is, as you learned earlier, there's always going to be your two electrodes, and so it's not monopolar energy. There's two electrodes. It's just a monopolar instrument, meaning that the instrument is one of the electrodes, and then the dispersive electrode, the one, again, erroneously called the grounding pad, is your second electrode in this scenario. So as was mentioned earlier, some of the current in this situation would be going through the patient. You do need to have an appropriate spot to place the dispersive electrode on the patient, somewhere without a lot of hair, avoiding metal, and avoiding bony prominences. And some of those factors may be reasons why sometimes you wouldn't use a monopolar instrument. But again, we don't want to call it any of the other things that are crossed out on the slide. When we talk about clinical use, there's several variables. We've touched upon them a little bit, but to go into some in more detail, sometimes the power setting, which is 20/20, 30/30, sometimes people just say random numbers when they start their case, but those are those two modes. cut, coag, and then you blend. And so typically most electrosurgical units, you'll be setting your cut and coag numbers. And the power setting, with the higher power setting, you want to think about higher voltage, higher risk of injuries. So we always encourage everyone to use the lowest power setting possible to achieve their desired tissue effect. And in a couple of slides, we'll go through how that's possible, because sometimes you might think you need to go up on the power setting with your monopolar instrument, but really you could just change your technique and change the things listed down here, like current density or proximity of tissue to the active electrode, and that's actually going to give you the tissue effect that you want, not just increasing your power setting. So a little more on that. What we're looking at here on the right side of the slide, this is a diagram showing what could be your electrosurgical pencil. And you've probably seen the middle one is kind of the more typical one that most of the packs come with. The one on the left has that little ball tip, and then on the one on the right is that little pinpoint one. And what we're looking at here is the contact area with the tissue. And so our current density, I think the next slide is even better, shows us that our tissue effects or thermal change, it's not just equal in terms of current density, it's actually exponential. So for every change we have here, making a smaller point of contact between our electrosurgical pencil in this example and our tissue, we're going to have an exponential increase in thermal change or tissue effect. So this is important to know when you're trying to have a different tissue effect, that you might just need to turn your monopolar instrument in a different direction if you're using the hook and you're just using the tip of it, versus using the elbow of it. Or maybe you need to switch to the spatula in order to have a larger tissue contact area. And so again, we see here our current squared over area is giving us that current density, and that's affecting our thermal change. A little bit more about the activation and whether you want to touch the tissue or not. Dr. Mandani touched on this. We try to avoid widely open air activation in terms of reducing injury with our monopolar instruments. He reviewed the injury, so I won't go into that. But just generally speaking, there are some modes where you don't quite want to be touching the tissue. So there's just a fine line. Some of that you just learn with time and practice. But essentially, if you're trying to make that perfect vaporization pocket, which is what's going to almost mimic using a scalpel and giving you a nice incision, if you like to use your energy device on skin, you would want to do that. That's going to be a near contact mode where you're not quite touching the tissue. That is different than open air activation where you're just like waving the pencil around in the air. That's dangerous. Using a near contact mode is going to give you that desired tissue effect. On the other hand, we could try, maybe we're now on our subcutaneous tissue and we want to have a slightly lower temperature to achieve some coagulation effect and desiccation as we see here. So then we do want to be in contact with the tissue, and that way we'll get some small vessel hemostasis in our subcu tissue. We see here in a higher voltage scenario, which is that coag mode, this is that interrupted waveform we talked about before with the higher voltage. Again, open air activation, when we say that, what comes to mind for me, the best example of this is really you've taken the gallbladder out, and whether it's open or laparoscopic, you now have a bloody bed. Perhaps it was a very inflamed gallbladder with a lot of tissue reaction, or perhaps the patient has some liver disease, and you've got a real situation in your gallbladder fossa. There's no actual vessels bleeding that are named. There's nothing you need to put a clip on, but you just need a surface coagulation. And so that's going to be our fulguration that we want to use. And that's when the coag mode, without quite touching the tissue, is going to be very helpful. You just sort of paint the tissue. And again, that's one of those things where sometimes people will try to use it, and they'll start and they don't have a lot of experience, and they'll be trying to do it, but they'll either be just a little too far away from the tissue or a little too close, and they won't see the desired tissue effect. And they'll go back to that number one on my slide. They'll go to, let's up the power setting. Let's do 50 coag, they'll say. And really, it's more of a technique. The safer thing for the patient is going to be to just over time practice and learn that perfect distance where you're able to get a nice coagulation, a nice hemostasis without increasing your power setting to make it a safer environment, lower risk of injury. So for monopolar instruments, one other point is another version of it, which you don't see as often, is the argon plasma coagulator. What this essentially is, it's a monopolar instrument. You do need a dispersive electrode, and you're using argon gas in order to sort of be the transportation for those electrons to get the current to the tissue. So it's highly efficient, and it's not flammable. So from those standpoints, it can be very helpful. I see people use it a lot for splenic bleeding or liver bleeding. Those are really the most common scenarios because it's very good at getting that surface fulguration and not having a lot of risk of stray energy. However, there are some specific risks to know if you do end up using the argon beam. The first one is with laparoscopy. It does not absorb into the tissues as quickly as the typical carbon dioxide does. Therefore, you could have higher intra-abdominal pressures than you intended to. You may want to lower your flow rates or vent to one of our filters, as was discussed in the last talk, that one of the filters that goes on one of your lap ports, you can vent out to that. Another risk is gas embolism, so you really don't want to be using this on a freshly cut surface right away. You could get into the blood vessels. And certainly you'd watch out for any signs of that, like hypotension. Also with the laparoscopy at the end of the case, again, I would use one of the filters to the trocar and try to get any of the residual pneumoperitoneum out that way, especially with argon, because the patient may have residual pneumoperitoneum longer than they would with CO2, which leads to shoulder pain and bloating. Not dangerous in that situation. It'll go away in a couple of days, but for the patient's sake, it's nice if you can find a safe way to get that air out of their abdomen. So moving on from our monopolar instruments, why do we use advanced energy, like advanced bipolar instruments? We try to get away from too many brand names in these talks, but I will just mention like ligature as an example, only because it's one you see in your ORs, and just to give you a tangible example in your head, with open surgery, that's usually the impact. With laparoscopic, there are several different versions of it. So that's a good example of an advanced bipolar device. Some of the reasons is to simplify the procedure or speed up the amount of time. A lot of these devices have vessel sealing capacity, but they also have the ability to cut the vessel. So you may be speeding up the procedure because you're not needing to put clips in and then cut, which is multiple instrument changes. Reduced blood loss has been shown with a lot of these advanced energy devices because they do provide a good seal, like we talked about with Dr. Mandani's slide. That coactive coagulation on cut mode is what these bipolar devices are achieving. They're really good for vessel control and sealing, and they're also good for dissection. A lot of them, you can get ones with the Maryland tip and dissect with it as well. So again, shorter OR time, fewer instrument changes. The bipolar devices do have the two active electrodes near the tip of the instrument, so you're not going to have to worry about energy going into other parts of the patient. I tend to use bipolar, maybe you have a patient with a cardiac device, which will be discussed later, and you know that you're far enough away, so generally you feel like you're safe because you've thought consciously about where you're putting your dispersive electrode, and you're going to keep your power settings low. I still just like the extra peace of mind of using bipolar if possible. I also tend to do that in patients with other types of random implants, nerve stimulators, things like that that are not in places that are helpful in terms of placing your dispersive electrode. Some of those are in the back and the lower back, and maybe in the path between your target tissue and your dispersive electrode. And so then it's just much easier to use bipolar. I also sometimes would use it for a head and neck situation where, again, I'm worried about OR fire and trying to reduce that risk. In the interest of time, I'm going to go to just some of our high-yield points on this. So advanced bipolar versus the monopolar instruments. Key things to think about. You don't need a dispersive electrode. Again, the energy doesn't need to get through the patient. You're using less voltage. You're in the cut form. The energy is staying between jaws. You're up to 7 millimeters, and they even have some newer ones that are up to 10 millimeters for the vessel size. So small named vessels, branches of named vessels, things like potentially a lap sigmoid colectomy, not for cancer, where you're on just sigmoidal branches. That's a great time to use an advanced bipolar, where you might, it would be quite tedious to sit there and clip things because they might be too big to take with a monopolar instrument. And at the same time, if you fire a stapler, you're not being nearly as precise. So you have this nice bipolar instrument to use there. Some of the big cons: thermal spread. 1 to 3 millimeters. We use advanced bipolar a lot around the stomach in foregut surgery and things like gastric sleeves. And often people do hug the stomach really close. You might even see the stomach blanch. So I think most of those situations you could take a 3 millimeter margin there and you're not going to significantly alter your surgery. And then you're really making it safer for the patient to not have as much risk of a gastric leak, because if you do have that thermal spread, several days later you might end up with a gastric leak that was actually an injury. Other cons, current leakage through cord, I mean, that's really more of a capacitive coupling issue that can happen with monopolar or bipolar instruments. And the cost increase. It depends on what surgery you're doing. If you're doing a surgery that's long and could have blood loss, then certainly that cost is offset by shorter OR time and shorter length of stay for the patient. If you're doing an appendectomy, it's a little bit hard to justify, depending on your math at your hospital. It may be hard to justify using an advanced bipolar instrument, though some hospitals do. A few things about the mechanism. Keep in mind, these advanced bipolars have really smart technology. I like to say it's smarter than we are, because it is. You should learn the audible signal that is telling you there's adequate coagulation. You don't need to double seal anything. This device is telling you because it's measuring the tissue between the jaws. And it's going to be right more often than we are in terms of that you're done. Now, one technique that I do use is if you're using it on a 7 millimeter vessel, the upsize of its limits, you could slightly overlap your seals. So what I'll typically do is 3 rounds of it, but not in the same exact spot. I'll go kind of proximal, then a little more distal, and then in the middle, and I only cut on the last seal. I would encourage you to try something like that. I would not recommend doing 2 or 3 seals in the same spot. You're not really going to accomplish very much, and you might just get more of that char, and then when you open the jaws of the bipolar, you may actually take some of that coagulum off with you, so it may be counteractive. So best practices, also tension is really important with bipolar. If you're using it to dissect, you may be pushing on tissue, and that's fine, but remember, when you go to use it for energy, if you're holding the vessel, you don't want to be holding it up or putting any tension on it, because then it won't get the adequate seal. We want to keep the jaws clean. They can be wiped off with just a little bit of a moist Raytec in between uses. And be careful with calcified vessels. There are some times when the vessel seal technology fails on a calcified vessel. Again, the thermal spread. This is a nice little table just to compare everything I've talked about, looking at the monopolar, advanced bipolar, and then your next talk is on ultrasonic. And so you can see that the risk of all of these types of injuries is going to be lower. You could still have inadvertent activation, for sure. Those buttons are very easy to accidentally press when it's down in the pocket, so be careful where you put your instruments when you're not using them. But in general, you can see the safety profile is definitely better for the advanced bipolar than the monopolar. And then just some final safe aspects. We've covered most of these, but just to hit the key points again, you want to consider the thermal spread. 7 millimeter vessels are appropriate or less. Adequate volume of tissue in the jaws and avoiding the hinge of jaws, that's a good one. If you look at your advanced bipolar instrument, there will be 2 hash marks, one towards the jaws and one towards the tip. That is the area that it's working in, and so you really don't want to take so much tissue that it's beyond that, or shove it so far into the hinge that you have tissue on either side that's not getting the full energy. It won't cut beyond the second hash, so at least from that standpoint, if you didn't quite get all the way there, you could grab the rest of the tissue. But I would advise you to do enough dissection first that your jaws are all the way around whatever you're trying to use it on for any vessel. Again, avoid traction or torque, and know that acoustic feedback of the system. So again, hopefully we've met these objectives in the last 10 minutes or 15 minutes or so, learning about those specific monopolar instruments, and hopefully have clarified for you some reasons why you might choose to use bipolar versus other times when you may choose to use monopolar. And I'll check the chat for any questions. Thank you.
Yeah, thank you, Jay. So that was an excellent review of monopolar and bipolar. There's one question up on the chat box, which isn't thermal spread for ultrasonic lower than advanced bipolar?
And it is. Well, I don't want to step on anyone's toes if the next person is going to cover that with ultrasonic, but it is, however, there's some trade-offs with that, which I'm sure will be covered. But it's still 1 to 3 millimeters, even for advanced bipolar.
Yep, so we can come back to that one after the ultrasonic talk, but we'll make sure we get a good answer. But yes, that is a true statement. Thermal spread is, or the thermal footprint, the lateral spread from the instrument tip is less for ultrasonic devices than it is for advanced bipolar. That's true. Okay, and I can see Dean is typing. Hopefully Dean is going to respond to Dr. Young's question. And thank you, Jay. So that was excellent. I just want to keep us moving because I want to leave a bunch of time at the end for questions. And so we're going to move on to Dr. Brett Parker. And Dr. Parker is one of our new FUSE members. So welcome, Dr. Parker. We really appreciate you joining us. And Dr. Parker is currently an advanced GI and foregut fellow in Portland, Oregon, and he finished his general surgery residency at the University of Buffalo. And Brett is going to talk about ultrasonic devices. Brett?
Absolutely. Thanks for having me, guys, and thanks for that great overview on monopolar and bipolar, Dr. Olasky. It's a nice segue with that question into my talk. So we're going to briefly go over ultrasonic energy and its use in the operating room, briefly review how it works, and best practices on its safe use. I'll try to go through this as quickly as possible because I know we're falling behind, and Dr. Robinson still has to speak on kind of the cardiac device. So we'll start now. So ultrasonic energy is a type of mechanical wave, and this definition is the energy is transported through a solid or liquid by motion or disturbance of the material. It's classified on this spectrum of frequencies that you can see here on slide 1. On the far left, less than 20 hertz, which is vibrations per second, you have what's known as subsonic energy, and this is energy that you can feel. Between 20 and 20,000 hertz, or the orange area here, you have frequencies that you can hear. So you have audible frequencies, and then moving up the spectrum over 20,000 hertz, you have ultrasound, and that's signified here with the red signal, and will be the primary frequency for the devices we discussed today. One confusing aspect, people hear about ultrasonic devices, they also think of ultrasonic diagnostic devices. And those are actually found at much higher frequencies. Usually they fall in the megahertz range, or 1 million cycles per second, and it's much higher on the spectrum, as you can see on the far right of this graph. Some of the more common devices, leaving as many brand names out today as we can. A lot of people think of the harmonic device or the Sonicision when talking about ultrasonic shears, and that'll sort of give you a couple of the more popular devices to hang on to in your mind when you go over how they work. So, here, a simple summary of how they work is that you have vibrating jaws which create friction against one another, and you have 3 primary modalities that are used to dissect tissue in the operating room. The first one is heat, the second one, mechanical disruption of tissue, and the third one is a phenomenon called cavitation. And we'll go through each of these independently and go over how they work. So the heat, as we previously mentioned, is basically caused by friction, and ultrasonic instruments can achieve thermocoagulation. The ultimate tissue effect of this thermocoagulation is similar to the electrosurgical devices that we've already gone over with dehydration and protein coagulation. However, the mechanism that causes the temperature in the tissue to rise is different. So with ultrasonic instruments, the tissue is heated with extracellular mechanical forces. Think of rapid massage of the tissue. With electrosurgery, the temperature elevation more occurs on an intracellular level with oscillation of intracellular ions. So, with ultrasonic energy, this disruption of molecular bonds causes denaturation of the protein, and then when the tissue subsequently cools, it can reform these bonds and transform it into that sticky coagulant after activating the device. So, for instance, if a surgeon were to clamp a blood vessel between the jaws of an ultrasonic device, the opposed walls would undergo this process and result being coaptic thermocoagulation or vessel sealing. So the second mechanism which ultrasonic energy uses to dissect tissue is mechanical disruption. And this occurs primarily through linear oscillation of the jaw in concert with a vibrating piezoelectrode, which we're going to go into in a bit more detail on subsequent slides. But this leads to transection or cutting of the tissue. And these effects are greatest in tissues which are dense, like muscle or collagen, or when the tissue is placed on traction.
Hi, Brett. Brett, out on the conference call, people are saying it's hard to hear you. So do you mind getting maybe a little bit closer to your microphone?
Can you hear me better now?
Yeah, that sounds better.
Okay.
Thank you.
Okay, I apologize for that. So I was just mentioning the ways that ultrasonic energy devices are used in the operating room. The final phenomenon is cavitation, and this is somewhat difficult to comprehend, but in general, it's a phenomenon that occurs in less dense tissue, such as fat, and leads to cellular vaporization, which expands the tissue that surrounds the jaws of the device, and the gaseous product forms these microbubbles or cavities that facilitates dissection and enhances the surgeon's visibility without smoke. So we're going to go through how these devices work so that they're fully understood and can use safely in the operating room. The overall theme is that electrical energy is converted to mechanical energy. And that works classically through a generator receiving electricity from a wall, usually AC current. There are some battery-powered ones now that deal with direct current, but the classic model receives current from the wall and upregulates it to a higher voltage, usually more than 23,000 hertz. And once this energy has been transformed into the higher voltage, it's sent to the handpiece, which is referenced as the transducer. So if you're thinking of some of these devices, they have these silver portions you screw into the back of the handpiece, and inside of those is the transducer, and it looks like this. The transducer's job is to convert electrical signal into mechanical energy or a mechanical wave. And it's kind of neat how it does this. So inside the handle of the device, there's a stack of piezoelectrodes positioned between copper cylinders. And when the electrical energy excites the electrodes, they expand and contract rapidly, which vibrates the cylinders at a very high frequency, usually around 55,000 hertz. They're attached to, as you can see on the right portion of this diagram, a solid shaft, which ultimately ends in the straight jaw of your dissecting blade. So consequently, the vibrational energy is transmitted down this shaft and oscillates that blade back and forth in a linear fashion in concert with the vibrating piezoelectrode. So it's a really neat mechanism that's been devised to convert electrical waves into mechanical waves and ultimately receive the tissue effect that I described earlier. So this is an overview of the mechanisms we've already described. Starting on the right side of this diagram, you have the generator. again, which receives electrical energy either from AC wall current or direct current from a battery. That electrical energy is sent to the transducer, which excites the piezoelectrodes and converts the electrical energy into mechanical energy, which is transmitted down the probe or the shaft of the instrument and ultimately to the tissue through the straight jaw of the dissecting blade. So now we're going to spend some time to go over how the device is used and some of the caveats and techniques that can be used inside the operating room to use it effectively. So in general, there are two main settings on the ultrasonic shear. This has to do with the amount of protrusion or length of oscillation of the straight jaw. So the longer the blade excursion, the more energy is transmitted to the tissue, the more mechanical energy is transmitted to the tissue. And this results in a greater cutting efficiency. Think about sawing a tree down with long strokes versus very short strokes. The max setting, again, which is larger amount of blade excursion, results in this more rapid cutting of tissue and hence less thermal spread, which intuitively leads to minimal hemostasis. The min setting, or minimal setting, leads to less excursion of the blade, which transmits less mechanical energy to the tissue and hence less efficient cutting. However, this slow setting leads to a greater degree of collateral thermal injury and ultimately provides better hemostasis. So the min setting is excellent because it has better hemostasis. So one thing that you can notice between the ultrasonic devices and the bipolar devices is there's a lot of user-dependent techniques that can influence the dissection. You have to make an intraoperative decision on which modality you want to use, which setting you want to use. And so these concepts are important to remember. There's also some other user-dependent techniques that can be utilized in the operating room to maximize your outcomes when using the device. And one of them is squeezing the blades together. This can be limited in some devices, but you can influence the efficiency of tissue cutting by squeezing tightly on the handle or not. Again, this is device dependent. Another technique that can influence your dissection is lifting up on the straight blade, which puts the tissue on tension and more pressure on the oscillating blade, the active blade. This can also increase your speed of cutting and minimize thermal spread. Again, in reference to the question that was asked earlier about thermal spread, this ranges usually from 1.5 to 3 millimeters on the ultrasonic device, depending on which setting you use. So the min setting, again, will have a higher range of normal, up to 3 millimeters of thermal spread, and the max setting would be closer to 1 reliably. And these user-dependent techniques that I've described can also affect the amount of collateral thermal injury, so are important to remember. There are newer models of the ultrasonic shears that have sort of advanced hemostasis buttons, and these basically use advanced algorithms to actively monitor the tissue condition while it's being activated, and it senses and responds intelligently to changes in the tissue, which also helps to reduce the risk of thermal damage. That's a common question that we get when talking about the settings. One very important aspect of ultrasonic surgical devices to remember is that there is a constant threat of collateral tissue damage or inadvertent thermal damage to surrounding tissues. The blade activation temperatures between the devices, between the two jaws of an ultrasonic device compared to a bipolar device is about twice as much. As you can see on the graph here on the top left, it approaches 200 degrees Celsius, whereas a bipolar device is just under 100 degrees Celsius. And that active blade, the oscillating blade, can retain heat and it stays hot after its activation. So if the surgeon is distracted or inadvertently touches this, this hot blade, which is not being actively used, it can lead to unintentional thermal injury, as you can see on this piece of bowel here. It's definitely something that has a learning curve, should constantly be remembered and constantly avoided when beginning to use this device. It's a great summary slide. In general, there are advantages and disadvantages of the ultrasonic shear when compared to bipolar and monopolar. Advantages, it does obtain thermocoagulation and vessels can be sealed. It can control vessels up to 5 to 7 millimeters depending on the device you have at your hospital. There is minimal spread of energy, which is user dependent and can be influenced by the technique in which you are using the tip of the instrument as well as the setting you have elected to use during dissection. There is no electricity inside of the patient, so there's no electrical circuit to consider. There's no dispersive electrode or capacitive coupling or insulation failures that you need to consider, and this will be highlighted further in the next talk when we talk about patients with cardiac implantable devices, which is a great advantage of the ultrasonic surgical shears. Disadvantages, again, it is user dependent. Heat can be retained in the active jaw that can offer the potential for inadvertent burns or thermal energy. The devices themselves can be more expensive and less available depending on your hospital. But overall, it's an exceptionally versatile device that is effective and safe when these concepts are understood. So at this time, I'll take any questions.
Thank you. That was an excellent presentation on ultrasonic devices. We did not get any questions up. I'll wait and see if anybody types in a question. So the answer before, it's interesting, it's a bit paradoxical in the sense that the ultrasonic device has a higher temperature and then results in residual heat injuries, as Dr. Parker said. And so it's a little bit counterintuitive why the lateral spread is less with an ultrasonic device, and that's because if you look at lateral spread, it's a coefficient multiplied by a delta in the temperature, and the coefficient has to do with the thermal mass of the tip of the instrument. The thermal mass of the tip of an advanced bipolar is much greater than that of an ultrasonic device, so even though the ultrasonic device gets much hotter, because the thermal mass is lower, the lateral thermal spread is less. And for those who love energy, that's a great, it's great. We twisted on that when we made the fused didactic. So how many times does it take for the tip to cool? Dr. Parker?
So I don't have an exact number for you. I tried to look into this, and as far as the timing goes, I did find the mean vessel seal time, which was about 8 seconds, but I'm not sure how long it takes to cool back to room temperature. I have seen that touching it on nearby benign tissue like fat may increase the cooling time, or excuse me, decrease the cooling time, but I'm sorry, maybe Dr. Robinson, do you have a better idea?
Yeah, it's interesting. So Brett, you quoted our paper. Henry Govakar and I wrote that paper on the residual heat, and we did those experiments. And we definitely did the time to cool off. And when you looked at it, it was more than 15 seconds if you did multiple activations in a row of the ultrasonic device. And I do think a intraoperative technical strategy that sort of the art of surgery, and so surgeons will touch the peritoneum or non-vulnerable tissue, and that cools the tip down quicker. But you can actually go to that reference that Henry and I wrote. I think Eddie was probably involved with that too, who gave a talk earlier. But we did residual heat for all the different types of instruments, from monopolar, bipolar, ultrasonic, and we did argon as well. And the residual heat is by far the greatest temperature for the ultrasonic device, and it took greater than 15 seconds. We have a nice time graph on how long it takes for it to cool down. All right, so thank you, Brett. That was a great presentation, and welcome to the Fuse group. I'm going to put up the last slide set, but I think it may be more important to answer questions. So let's see if anybody has questions. I'm going to start this talk, but I'm going to be also respectful of your time because we have 7 minutes. And so I'd rather make this interactive. Dr. McCommy's talk got a ton of questions. So if you have questions on the smoke and aerosolization, please type them in and we'll let Dean cut in. And we'll be timely here. But I'll go ahead and get rolling. As we were sitting here, I basically said, well, I'm not going to cover the whole thing. We'll just cover the highlights. And because this is a surgical group, we'll cover the more surgical aspects of this. So I think the background is, look, if you've got a implantable cardiac device, that'd be a pacemaker or an internal defibrillator. If you disrupt the function of that device, that's a bad thing for the patient. And so when you hit your monopolar device, so when you hit the activation of the button with the bovie, it causes electromagnetic interference. And you can see that like on your video monitor. I don't know if anybody has seen it. Every once in a while when you activate the monopolar instrument, your video screen will have become hazy, and that's electromagnetic interference. So that your monopolar, because it has such high voltage, as explained to us earlier, it creates a lot of electromagnetic interference, and it disrupts the other electronic devices that are around it. And if your screen gets a little hazy, that's okay, but if you all of a sudden don't trigger your pacemaker, that's a huge deal. And so the Fuse program really looks at this. What I'm going to do is I'm going to look ahead in these slides, and I'm going to go down to the ones that are let's see if we can zip down. Let me go to a couple more here. I first go over just briefly, there's guideline statements that go over like how we should do a preoperative evaluation. And so we have some slides on this, but because this is a surgical group, I'm going to do the second half of the talk, but I'm happy to talk about any part of this. And this is what you can actually do in the operating room. You as a surgeon, what you can do to reduce the chances that your monopolar instrument or the bovie will interfere with the implanted cardiac device. And so these are the variables that are associated with disruption of your cardiac implanted device. So we're just going to go down and we're going to march down them in order. So we're going to start with the proximity of the active electrodes, that's your monopolar pencil, to the device. And so the practice advisories state you should avoid proximity of the cautery, and what they're talking about is the electrosurgery tool, electrical field to the pulse generator or the lead, so that's the cardiac implanted device. And the other practice advisor says electrosurgery applied below the umbilicus is much less likely to cause electromagnetic interference. And so we actually tested this in the lab with quite a few members of the Fuse group, and most particularly Dr. Rosner, who has since passed away, but he was really the person who really put this together for the Fuse group. What we did is we floated a pacemaker in a live, it was an in vivo experiment in a pig, and then we used the electrosurgery device at various distances from the tip. This is the tip of the pacemaker. And when you're right over the tip of it at 0 centimeters, you cause the most electromagnetic interference that we read on an oscilloscope coming off the lead here. And as you get further away, and it seemed to plateau once you get down to 10 centimeters. So the rule of thumb that you see in these guideline statements that once you're below the umbilicus is about, in an adult, is about 10 centimeters away from this tip of the cardiac implanted device. I'm sitting here pointing with my pointer, and I need to be pointing with this little green guy here. Let me see if I can bring him down. I cannot, so that's okay. So, but anyway, you have to be at least 10 centimeters away. Now, you can't always control your surgical field is, but distance is the first variable that the surgeon can control. The second one is you're going to say, what's the current vector pathway? It sounds complicated, but it's very, very straightforward. And so let's go over what that actually means. So what that means is, so what we learned from Amin is that even though we call it a monopolar instrument, it's bipolar because there's a dispersive electrode and an active electrode. And the current travels through the patient between the tip of this tool to the dispersive electrode. And it actually travels back and forth because it's alternating current. So what you don't want to do is place your dispersive electrode up here so that the current travels up. You don't want to place it up on the shoulder so that the current travels up through the pacemaker device, so it disrupts the device. So you want to put it so that the current is routed away from either defibrillator or pacemaker. All right, I'm going to do one more minute here, and then I think we'll shut it down. But so we have orientation of active and dispersive electrode cords. So it turns out that the active electrode cord and the dispersive electrode cord both give off, they radiate this electromagnetic interference. So if you're operating on a patient with a implanted cardiac device, you want to put your electrosurgery generator at the feet so you can drape the cord up from the feet so that the cord does not drape over or adjacent to the pacemaker. So the image on the left is how you should not do it because you're going to get more electromagnetic interference on your cardiac device. Whereas the image on the right, where you keep the cord draped up from the feet, that's the way you want to do it. And so we're at 6:59, so let me just see on the slides here if we have any questions, because I want to make sure I'm more interested in getting your questions answered than kind of pounding through the material. So Joe, you said the initial slides of your must be PowerPoint talk were very interesting to me. Would you be able to send them? Yeah, 100%. I think we'll send them out. So if you reach out to the Fuse group, you can go to fuseprogram.org, or you can just send me an email. I had my email on the first slide, so I'm going to go back to the first slide so you can see my email. I'm absolutely happy to send you the slide deck. There's my email down here. And so you can write that down, Joe. Does anybody else have any questions? Vanessa, let's see if we can get Dr. McGetsy's question in, and we'll do this as the last question. I hear the dogs barking in the back. They know it's 7 p.m. and everybody, or it's 7 here in Denver. Out there's Dean. Hello, Dean. Anybody else? So are we able to get a recording of this lecture? Well, let me ask Steve Lamb how that works, because Steve may know, but I believe they post this on the SAGE's website for people to access in the future. Yes, this is recorded. So once again, you can go, that you would access through SAGE's and then access the history of the webinars. We did this same webinar in 2017, 2018 in the fall, and so there's a couple of them up, but they're very similar. And so with that, I think we'll close it out. And the first thing is I'd really like to thank all of our speakers. I think this was a tremendous review of electrosurgery, very comprehensive, and I appreciate your time and effort in doing this. And thank you to the attendees, and this concludes the Fuse 3.0 webinar. Thanks, everybody.